The conversation around veteran care is reaching a fever pitch, and we need to talk about the silence that's louder than any protest. The sound of thousands of veterans quietly closing their VA files and walking away from the system entirely. We're not talking about minor dissatisfaction. We are witnessing an unprecedented exodus, a silent vote of no confidence that is accelerating right now, and by 2025, the impact will be undeniable, reshaping the landscape of veteran support forever. This isn't just about long lines or bad coffee. This is about deep systemic failures that are pushing the very people the system was designed to serve into the arms of private care, often at great personal expense, simply because the friction of staying is greater than the cost of leaving. If you're a veteran, or if you know one, you've probably felt this tension, this exhaustion, this sense of being trapped in a bureaucratic labyrinth that seems designed to defeat you, not heal you. We've identified 8 critical pressure points, 8 reasons why this massive migration is happening. And the first reason is perhaps the most frustrating, because it's entirely solvable. The crushing weight of the digital divide and the endless bureaucratic maze that turns simple healthcare into an administrative nightmare. Imagine trying to navigate a modern healthcare system using technology that feels like it was last updated during the first Gulf War. And that is precisely the daily reality for countless veterans attempting to interface with the VA. The core failure here is the inability of the Veterans Health Administration to integrate its technological platforms into a cohesive, user-friendly experience, creating a fragmented landscape where essential tasks become Herculean efforts. Veterans are forced to juggle multiple non-communicating portals: My Health Vet for messaging and basic records, e-benefits for claims status, and the newer VA Gov for centralized applications, each with its own login protocols, security requirements, and inevitable downtime. This digital fragmentation is not merely an inconvenience. It is a significant barrier to care, particularly for older veterans or those dealing with cognitive impairments related to service-connected conditions like traumatic brain injury, where complexity translates directly into missed appointments and delayed treatment. Think about the simple act of scheduling an appointment, instead of a seamless modern online booking system that allows immediate visibility into provider availability. Veterans often find themselves trapped in an endless cycle of phone tag, leaving voicemails that are rarely returned promptly or being routed through automated systems that terminate the call before connecting them to a human being. The frustration is compounded when a veteran needs to coordinate care across different departments: mental health, primary care, and physical therapy, as these systems frequently do not communicate internally, requiring the veteran to act as their own administrative assistant, manually transferring information and confirming referrals that should be instantaneous. This administrative burden is amplified by the persistent issue of paperwork overload, where the system demands physical forms, faxed documents, and wet signatures for processes that were digitized in the private sector a decade ago, leading to crucial information being lost in transit, forcing veterans to resubmit documentation repeatedly. Consider the sheer effort required just to update an address or change primary care providers. This often involves initiating a complex chain of requests across multiple departments, each requiring verification and manual processing, leading to delays that can stretch into months, during which time prescriptions might be sent to the wrong location or critical follow-up instructions are missed. This reliance on outdated, cumbersome technology not only frustrates the veteran, but also slows down the providers, forcing highly trained medical professionals to spend an inordinate amount of time wrestling with antiquated computer interfaces and documenting information redundantly rather than focusing on patient care. The VA's slow, often years-long rollout of modernization projects, frequently plagued by budget overruns and technical glitches, signals to the veteran community that improving their daily interaction with the system is not the priority, reinforcing the feeling that they are dealing with a slow-moving, unresponsive bureaucracy rather than a dynamic healthcare provider committed to efficiency and ease of access. When a veteran realizes they can book an appointment with a private physician, receive instant digital records, and communicate securely with their doctor through a single app. The stark inefficiency of the VA's digital infrastructure becomes a powerful motivator to leave the system entirely, seeking the simplicity and reliability that modern technology should afford them. The cumulative effect of this digital friction is exhaustion. Veterans aren't just seeking better medical care, they are seeking relief from the constant, low-grade stress of navigating a system that seems fundamentally broken at the most basic operational level, and for thousands, the only sustainable solution is to exit the maze. The second deeply distressing reason for this mass departure centers on a fundamental crisis of confidence in mental health care, specifically regarding the timeliness, specialization, and confidentiality of the support offered. When a veteran reaches out for mental health services, they are often at a critical breaking point, and the system's response, or lack thereof, can be devastating. The primary failure point here is the staggering wait times for initial appointments and, crucially, for follow-up specialized care. While the VA may tout short average wait times for an initial intake, the reality for veterans seeking specialized trauma therapy, such as prolonged exposure or eye movement desensitization and reprocessing, EMDR, is often a multi-month delay, forcing them to endure their suffering during the very period they are actively seeking help. This delay is exacerbated by a severe shortage of clinicians trained in specific, modern trauma modalities that move beyond basic talk therapy and medication management, leaving many veterans feeling that the only solution offered is a prescription pad, which often fails to address the deep-seated root causes of their combat or service-related stress. Furthermore, the standardization of care within the VA often overlooks the unique complexities of military trauma, particularly issues like moral injury. The profound psychological distress resulting from actions or inactions that violate one's deeply held moral or ethical beliefs, which requires highly specialized therapeutic approaches that many general VA mental health providers are simply not equipped to deliver effectively. Veterans report feeling unheard, minimized, or pigeonholed into generalized diagnoses that fail to capture the nuance of their experience, leading to a profound lack of trust in the provider-patient relationship. This lack of specialized expertise is coupled with the pervasive, paralyzing fear of confidentiality breaches and the potential impact seeking help could have on their career, security clearance, or ongoing disability claims. Despite assurances, the perception remains that admitting to severe mental health struggles could be weaponized against them by the very system responsible for their care, creating a chilling effect where veterans either minimize their symptoms or avoid the VA entirely, opting instead for expensive, out-of-pocket private therapists who guarantee complete separation from military or governmental records. The pressure on VA clinicians, driven by immense caseloads and the bureaucratic requirements of documentation, often leads to rapid, impersonal sessions that feel more like checklist reviews than genuine therapeutic encounters, further eroding the veteran's willingness to open up about deeply painful or traumatic experiences. The system's struggle to provide adequate support for substance use disorders that frequently co-occur with PTSD is another major contributor to the exodus. With limited bed space for inpatient treatment and often rigid, one-size-fits-all outpatient programs that fail to address the complex interplay between addiction and trauma. When veterans observe that the private sector offers immediate access to highly specialized, confidential, and holistic mental wellness programs, including neurofeedback, specialized retreats, and trauma-informed physical therapies, they recognize the stark contrast with the VA's often reactive, under-resourced, and generic approach, leading them to prioritize their mental survival over the administrative convenience of staying within the system. The failure to provide timely, specialized, and truly confidential, Mental health care is not just a service failure. It is a life and death issue that veterans are choosing to resolve by seeking help elsewhere, recognizing that the VA's current mental health infrastructure, despite the best intentions of its staff, is simply not capable of meeting the scale and complexity of modern military trauma. Moving on, the third monumental driver of this exodus is what many veterans universally refer to as the compensation claim nightmare, an adversarial process that transforms the quest for earned benefits into a prolonged, emotionally devastating legal battle. The fundamental issue is that the VA's claims process is structured not as a supportive assessment of need, but as a bureaucratic gauntlet designed to minimize liability, requiring the veteran to prove, beyond a shadow of a doubt, that their current suffering is directly and continuously linked to specific events that occurred decades ago, often with inadequate or missing documentation. The sheer length of time required to adjudicate a claim, often stretching into multiple years, especially with appeals, inflicts a crushing financial and psychological toll on the veteran and their family, forcing them to live in limbo, unable to plan their financial future while managing debilitating service-connected conditions. Central to this nightmare is the compensation and pension (C&P) exam, which many veterans view as the most stressful and hostile part of the entire process. These exams, often brief and conducted by contractors who may lack specialized knowledge of the veteran's unique military role or injury profile, frequently result in decisions that contradict the veteran's own private medical records or the opinion of their treating VA physicians. Veterans feel that the C&P examiner's primary role is to find reasons to deny or minimize the disability rating, rather than objectively assess their condition, leading to an immediate breakdown of trust in the fairness of the system. The complexity of the required evidence is overwhelming. Veterans must navigate the labyrinthine requirements for nexus letters, medical opinions, lay statements, and official service records, all while dealing with the cognitive effects of their injury, necessitating the costly and often frustrating involvement of veterans service organizations, VSOs, or private claim consultants. The constant pressure to provide more evidence, even after submitting comprehensive documentation, creates a cycle of endless appeals that can consume a veteran's life for years, turning their focus away from recovery and towards administrative warfare. Consider the specific difficulty surrounding presumptive conditions, such as those related to Agent Orange or burn pit exposure. Even with landmark legislation like the PACT Act, the implementation remains slow and fraught with bureaucratic resistance, requiring veterans to continue fighting for recognition and care for illnesses that the government has already acknowledged are service-connected. The process of requesting an increase in disability rating, even when a condition has clearly worsened, often mirrors the initial claim process, forcing veterans to repeatedly relive their trauma and justify their suffering to examiners who may only spend 15 minutes reviewing their decades-long medical history. For veterans who are already struggling financially, the lengthy wait for benefits means delayed access to critical resources, housing assistance, and educational benefits, trapping them in a cycle of poverty and poor health. When a veteran weighs the immense emotional and administrative energy required to maintain or increase their benefits through the VA against the immediate, albeit expensive, care they could receive privately, many are choosing to abandon the claims battle entirely, viewing the emotional cost of fighting the system as too high a price for the earned compensation. This claims nightmare is not just about money. It is about dignity, recognition, and the promise made to them during their service, and the VA's failure to deliver on that promise efficiently and compassionately is pushing veterans out the door in droves. The fourth major systemic failure driving this exodus is the dramatic and often dangerous quality of care disparity, creating a postcode lottery where a veteran's access to specialized, high-quality medical treatment is determined almost entirely by their geographic location, specifically the stark difference between urban flagship medical centers and remote rural clinics. Veterans residing near major metropolitan areas where large VA medical centers are located often have access to state-of-the-art facilities, specialized surgeons, advanced diagnostic equipment, and a wider range of subspecialty clinics, providing a level of care comparable to top private hospitals. However, the vast majority of veterans do not live within convenient driving distance of these flagship centers, relying instead on community-based outpatient clinics, CBOCs, or smaller regional facilities that are chronically under-resourced. The disparity is immense. These smaller clinics often lack the infrastructure for complex procedures, forcing veterans to endure extensive, often multi-day travel just for routine specialty appointments. Imagine a veteran living in a remote part of the Midwest needing regular oncology checkups or complex cardiac care. The requirement to travel hundreds of miles, often necessitating hotel stays, time off work, and significant disruption to family life, transforms essential medical care into an unsustainable logistical burden. This travel requirement is especially punitive for veterans with mobility issues, chronic pain, or those who rely on VA transportation services, which are themselves often unreliable and slow. Furthermore, the CBOCs frequently suffer from a severe lack of specialized providers. They may have primary care physicians and basic mental health staff, but specialists like neurologists, endocrinologists, or pain management experts are often only available via telehealth, a service that, while useful, is not always adequate for hands-on examinations or complex diagnostic work. The reliance on locum tenens, or rotating contractors in these remote locations, also means a critical lack of continuity of care. A veteran might see a different specialist every few months, forcing them to re-explain their complex medical history repeatedly, eroding trust and leading to fragmented treatment plans. The quality of basic diagnostic tools can also vary wildly. Some rural clinics may have outdated imaging equipment or limited laboratory capabilities, requiring samples to be shipped long distances, delaying diagnosis and treatment initiation. This disparity sends a clear message to veterans in rural or underserved areas. Your health is less of a priority than that of your urban counterparts. When these veterans realize that by opting out of the VA system, they can utilize local, albeit expensive, community hospitals and specialists who are geographically accessible, the choice becomes clear. They are essentially trading the free but logistically impossible care of the VA for the immediate, convenient, and reliable care available locally, even if it means incurring significant financial strain. The failure of the VA to standardize the quality of care and access to specialty services across all geographical boundaries is a systemic inequality that is directly fueling the abandonment of the system by those veterans who need reliable, local access the most. The fifth critical friction point, and one that promised relief but delivered complications, is the failure of the community care program to live up to its promise, revealing the hidden cost of external referrals. The idea behind community care, allowing veterans to seek care from private providers when the VA cannot offer timely or geographically convenient services, was sound, designed specifically to address the access issues highlighted in the previous point. However, the implementation has been plagued by bureaucratic bottlenecks and administrative chaos, transforming what should be a seamless transition into a frustrating, multi-layered obstacle course. The primary issue is the authorization process. Obtaining approval for community care is often a painfully slow, opaque procedure, requiring multiple levels of review and sign-off, during which time the veteran's condition can worsen. Veterans frequently report waiting weeks or even months for the necessary authorization codes, often only to find that the referral has been denied for vague or technical reasons, forcing them to restart the process. Even once authorized, the system often fails spectacularly in the logistics and billing integration. Private providers, unfamiliar with the VA's complex billing codes and authorization windows, frequently experience significant delays in payment or outright denial of claims, leading many high-quality private practices to simply stop accepting VA referrals, further limiting the veteran's options. This leaves the veteran caught in the middle. They receive a bill from the private provider because the VA hasn't paid, and then they spend countless hours on the phone trying to mediate between the private billing department and the VA's sluggish payment processing center, often receiving conflicting information from both sides. This financial uncertainty and administrative burden place immense stress on the veteran, turning a necessary medical appointment into a financial liability and a logistical nightmare. Furthermore, the promise of integrated care often breaks down completely in the community care environment. Private providers rarely have direct, real-time access to the veteran's full VA medical history, and the VA frequently struggles to integrate the private provider's notes and test results back into the veteran's official electronic health record promptly, leading to fragmented care and the risk of redundant testing or dangerous medication interactions. The veteran is once again forced into the role of the medical records courier, hand-carrying documents, or ensuring faxes are sent, an absurd requirement in the 21st century. For conditions requiring ongoing complex coordination, such as chronic pain management, cancer treatment, or complex surgery follow-up, the lack of seamless communication between the VA and the community provider creates significant gaps in care and increases the risk of negative health outcomes. Veterans who initially sought community care for faster access are now exiting the entire VA system because the administrative complexity of managing the community care referral process is proving to be more stressful and damaging than simply paying for private care out of pocket. They realize that true autonomy and integrated care require cutting the bureaucratic umbilical cord entirely rather than relying on a partially outsourced system that creates double the paperwork and double the liability. The sixth major contributing factor to the mass exit is the profound impact of staff burnout and high turnover rates within the VA, which directly sabotages the continuity of care and the vital trust relationship between the veteran and their provider. Healthcare is fundamentally built on relationships, and when a veteran finally finds a primary care physician, mental health therapist, or specialist who understands their complex history and unique needs, a relationship that can take years to build, the sudden departure of that provider due to systemic pressures is deeply destabilizing. VA medical staff, particularly nurses and physicians, frequently cite overwhelming caseloads, mandatory administrative burdens tied to the outdated technology discussed earlier, and salary caps that are often significantly lower than the private sector as primary reasons for leaving. This high rate of turnover creates a revolving door effect. Veterans are constantly assigned new primary care teams, forcing them to reestablish trust and repeatedly recount traumatic or complex medical histories to a fresh face who has no institutional memory of their case. This repetition is not only emotionally taxing, but also leads to gaps in treatment, as the new provider may not fully grasp the nuances of previous treatment failures or successes. The lack of continuity is particularly damaging in mental health and chronic pain management, where consistent, long-term therapeutic relationships are essential for progress. When a veteran has established a fragile level of comfort with a therapist and that therapist leaves, the veteran often interprets this as a form of abandonment by the system, reinforcing feelings of isolation and distrust. Furthermore, the burnout among the staff who remain is palpable. Overworked and stressed clinicians often have less time and emotional capacity to dedicate to each patient, leading to rushed appointments and a perceived lack of empathy, which further alienates the veteran seeking support. The VA relies heavily on hiring new, often inexperienced staff to fill these gaps. And while new talent is necessary, the constant cycle of training and subsequent attrition means that the institutional knowledge required to navigate the VA's own complex internal processes is frequently lost, leading to more administrative errors and delays for the veterans. Veterans recognize that the VA is struggling to retain top talent due to these systemic stressors, and they are increasingly choosing to follow highly skilled, specialized providers who have moved to the private sector, knowing that a stable, long-term relationship with a high-quality provider is worth the financial investment. The staff exodus is not merely an internal HR problem. It is a direct failure of service delivery that undermines the core mission of the VA and forces veterans to seek stability and consistent expertise outside the system that cannot retain its best people. We must also confront the seventh critical issue: the VA's persistent failure to rapidly and effectively adapt to the complex, multifaceted injuries of modern warfare, particularly in the areas of traumatic brain injury, TBI, toxic exposure illnesses, and holistic chronic pain management. The nature of conflict has evolved dramatically since the VA's foundational structure was established, and the injuries sustained by veterans of the Global War on Terror, GWOT, often involve complex syndromes that defy simple diagnostic categories. TBI, for example, rarely occurs in isolation. It is frequently intertwined with PTSD, chronic pain, cognitive deficits, and endocrine disruption, requiring highly specialized, integrated neurological and psychological care. While the VA has established TBI centers, access to these specialized multidisciplinary teams is often limited, and the standard of care in general VA settings often defaults to siloed treatment: a psychiatrist for mood, a neurologist for headaches, and a physical therapist for mobility, failing to treat the TBI as a single, complex system disorder. This fragmentation leads to conflicting diagnoses and ineffective treatment plans. Furthermore, the issue of toxic exposure, particularly the long-term effects of burn pits, has created a wave of complex respiratory, autoimmune, and oncological illnesses that the VA was initially slow to recognize and address. Despite the passage of the PACT Act, which expanded presumptive conditions, veterans are still struggling to access comprehensive, cutting-edge treatment for these novel illnesses. Many veterans feel that the VA's standard protocols are decades behind the latest research in environmental medicine and complex chronic disease management, forcing them to seek out private specialists who are at the forefront of treating these specific, service-connected toxicities. The most egregious failure in modern injury management, however, is the VA's approach to chronic pain. Following necessary reductions in opioid prescriptions, the VA struggled to pivot towards effective, non-pharmacological, and holistic pain management modalities. While programs exist, access to comprehensive interdisciplinary pain clinics that integrate acupuncture, specialized physical therapy, behavioral health, and interventional procedures is often geographically restricted and plagued by long wait lists. Veterans dealing with intractable pain feel abandoned, offered either a limited physical therapy prescription or a return to basic pain medications, neither of which addresses the fundamental complexity of their chronic condition. This lack of sophisticated integrated pain care is a major reason veterans leave, seeking private clinics that offer cutting-edge regenerative medicine, advanced neuromodulation techniques, and highly personalized comprehensive pain programs that treat the veteran as a whole person, not just a symptom checklist. The inability of the VA to consistently deliver rapid, research-driven, integrated care for the signature wounds of the 21st century signals to veterans that their complex modern injuries are better understood and treated in the private sector, driving them to prioritize specialized expertise over institutional convenience. Finally, the eighth, and perhaps most philosophical, reason why thousands of veterans are walking away from the VA system is the profound search for dignity, autonomy, and the right to be treated as a valued client, not a bureaucratic burden. At its core, the VA system, despite its best efforts, often operates under a model that treats the veteran as a recipient of charity or an object of government responsibility, rather than an empowered consumer of healthcare services. This manifests in countless ways: the lack of choice in providers, the mandatory, often humiliating requirement to justify every medical need through the claims process, the inability to easily provide feedback that results in meaningful change, and the constant feeling that they must fight for every single earned benefit. Veterans are highly disciplined, mission-oriented individuals who value efficiency and control, and the VA system, with its inherent slowness, complexity, and paternalistic approach, directly clashes with these values. When a veteran uses the private healthcare system, they are treated as a client. Appointments are scheduled quickly, communication is direct, and the expectation is that their needs will be met efficiently because they are paying for a service. This shift in dynamic from being a supplicant in the VA system to being a client in the private sector is incredibly empowering and restores a sense of control that is often stripped away by military service and subsequent bureaucratic struggles. Furthermore, the rise of specialized, veteran-focused private wellness organizations, often run by former military personnel, offers a sense of community and understanding that the vast, impersonal VA system often fails to provide. These organizations prioritize holistic wellness, rapid access, and a culture of mutual respect that resonates deeply with the veteran community. For many, leaving the VA is not just a medical decision. It is a psychological and emotional declaration of independence. It is the realization that they can achieve better health outcomes, faster appointments, and a greater sense of respect by investing in their own care and severing ties with the system that has historically caused them immense stress and frustration. The cost of this dignity is high, often involving thousands of dollars in annual out-of-pocket expenses, but for a growing number of veterans, the price of staying within the bureaucratic friction of the VA system is simply too high for their mental and physical well-being. They are seeking autonomy, and the only place they are consistently finding it is outside the walls of the Veterans Health Administration. The reality we face in 2025 is stark. This quiet exodus is not just a temporary trend. It is a fundamental rejection of a system that has failed to evolve with the needs of the modern veteran. We have detailed 8 critical pressure points, from the archaic digital infrastructure and the soul-crushing compensation claims process, to the crisis in specialized mental health, the geographic inequality of care, the failure of community care integration, the instability caused by staff burnout, and the inability to adapt to modern injuries, all culminating in a profound search for dignity and autonomy. The cumulative effect of these failures is creating a two-tiered system where veterans with the financial means and administrative savvy are opting for private care, leaving the most vulnerable, those who are geographically isolated, financially strained, or suffering from the most complex conditions, trapped in a struggling, increasingly under-resourced VA system. If this trend continues unchecked, the VA will face a critical challenge. Losing its best client base means losing the data, the funding justification, and the political capital needed to implement the massive, necessary reforms. The time for minor adjustments is over. Veterans are voting with their feet, and their message is clear. The system designed to heal them is instead exhausting them, and until the VA can deliver timely, integrated, specialized, and dignified care without the crushing administrative burden, the exodus will only accelerate, leaving the promise of comprehensive veteran health care in serious jeopardy. The question is no longer if the VA system is failing, but how many more veterans must walk away before the systemic failures are finally, truly addressed.